In Malaysia, good quality data on breast cancer is not available. The National Cancer Registry last report was in 2006, and it's reported that our incidence is 46 per 100,000. This comes to about 1 in 20 women in Malaysia will get breast cancer, and this is half the rate that we would see in the West. Malaysia is a high middle-income country and is developing very rapidly. And with development, we find that the incidence of breast cancer will definitely increase in the next 10 years. Currently, in my hospital, we see about 550 new cases of breast cancer a year, which probably accounts for about 15% of breast cancers in the country. And we have three main races here, the Indians, Malays, and Chinese. And the levels of economic development in the culture in these three groups are very distinct. The most important thing we find is that in the Malay population, in Malay women, 40% of them present with late-stage breast cancer. It's actually social cultural barriers, and late diagnosis continues to be a problem. So the challenge would be in identifying all these reasons why women present late, and this needs a lot of psychosocial research. Our main constraint now is manpower. We do not have enough breast surgeons. Not only breast surgeons, we need the supporting staff. We need a breast care nurse. We don't have breast care nurses in most places. And psychological support for women with breast cancer is lacking. The other solution to our poorer survival is treatment. We need to give optimal treatment. But the challenge is actually getting the budget to do it. The areas that we really need to concentrate on in Malaysia, this is what I feel, is actually research. Because we want to know, we need to have research into clinical epidemiology, because we need to see how women present. The other area of cancer care that we need to look into, which might improve quality of life, not so much outcome, is psychosocial support. We do have things like research into husband support for women with breast cancer. That's important. So education of the women, not only of the woman but of her family, is an area that could improve results. Given everything that I have said, I feel that there is hope for improvement in the future, because I feel that as the chairman of the clinical practice guidelines, I have the opportunity to use what I have learned being a member of the BHGI into stratifying resource levels, because we have to realize that breast cancer is just one part of cancer care. We also have other cancers to think about, and we have to be fair to all. So the BHGI resource stratification is quite important, because as a high middle income country, we should practice at an enhanced level, but we are practicing at the limited level where women get access to anthracyclines, but not to taxanes and not to Herceptin. They get access to tamoxifen, but not to aromatase inhibitors. And when it comes to metastatic breast cancer, treatment is lacking because the usual attitude is that it's not curable. Why are we spending so much money? But we feel that it is very important for quality of life. So I do hope that in the future, our women will have more optimal treatment for breast cancer. And also, we will be able to improve survival, which is the end point.